Hi, my name is Bob, and I'm a recovering lawyer. I want to thank the National Health Council for having this here today. I guess that's working great. So, additionally, just thank you all for all the work that you've done, both for ACA implementation and to get it over the finish line. It is a huge step forward, at least in the Academy's view, and obviously there's a lot more work to be done. So, in that context, oh, thank you very much. Okay, great. So, one thing that we interact with as providers, which is probably a lot different than many of the other provider groups in the DC space, is we're the Medicaid doctors, right? More than half of the people on Medicaid are children. And so we interact with Medicaid all throughout these United States. And we also have a little bit of background with the CHIP program. And in regards to the first presentation, you know, the history of CHIP, I think, is kind of similar in some ways to what we might see going forward with the Medicaid expansion. I'm very interested in what Sonia has to say, but I remember working in the state of Texas when I was getting my graduate degrees and sort of working for the Department of Insurance, and I did say that like a Texan insurance, not insurance. You know, what we dealt with was this question of crowd out. We were doing reports, you know, all this other kind of stuff, and eventually Texas got there, right? I mean, they still have a lot of kids who are uninsured and a lot of adults who are uninsured as well, but they took the money eventually. So it does seem like a pretty good deal, even better than the CHIP money was for most states. And you know, when you do see the pressure from provider groups, including ours, hospitals, et cetera, there really is, I think, a strong rationale. I do think that does sort of play into this other discussion, though, about Medicaid and about other entitlement spending. Generally, our perspective is that Medicaid is not the problem. I used to use a slide in this presentation, or presentations like this, that sort of showed these different graphs and increases in you know, the cost of different programs. Medicaid was one that just sort of always chugged along, and I used it to try to show that Medicaid is really an incredibly efficient and effective program at getting kids and other enrollees what they need. This is a per capita cost, and when you look at it, the cost growth for Medicaid is really less than half of what you see in private insurance. Now, I would argue that's because my doctors don't get paid very well in Medicaid, but at the same time, probably AHIP and others might argue that's because the private insurers are paying the penalty or a tax, essentially, for the low payment rates on the Medicaid side. Nevertheless, if you look at the way that Medicaid has historically worked, it is not a very expensive program per capita in terms of coverage. Now, health spending is the overarching issue, and in terms of the deficit reduction debate we're going to have, this has to be addressed, right? And really, you know, if you go back to Peter Orszag's writing and some of the other folks who are arguing for the ACA, that was what the ACA was designed to address, right? We need to get a handle on health spending overall. It's just the point I'd like to make is that Medicaid is not the driver of that, even with the expansions. Now, the other perception that we have is that, you know, kids are different than the rest of the population. This is a slide of poverty rates in the United States. If, you know, another thing that's been going on is we've been in a downturn. Economic downturn has been endemic across the United States. As a result of that, you know, what happens in downturns is that kids really take it on the chin. If your family loses their house, that kid is going to be ripped out of their school. They're going to have to go to a different community. They're going to have to, you know, just deal with all of these different challenges that you or I might not face. We don't automatically have to change jobs necessarily if something gets messed up with that family. Right now, we're at 22% poverty for kids in the United States. That is a jarring and shocking figure, and I think it really does call for some sort of solutions to that problem. I don't know if it's spurring jobs to create more you know, health insurance for kids as a result of those jobs, or if it's more federal spending to actually help children, but this is creating a whole generation of kids who are really having to deal with those challenges that poverty creates. So, in terms of the Academy's advocacy on the ACA, both before, during, and after the Supreme Court decision, we really focused on the ABCs, right? Access, benefits, and coverage. In order to get kids really in the door, you need to make sure that, one, there's enough providers to see them. So that's a workforce issue as well as a payment issue. Two, kids are very different than adults. They need different benefits than adults do. Most of the time, they really don't need many prostate cancer tests or breast cancer screenings. They do, however, need immunizations. And it's just a different mode of services that children need, and so they need a benefit package that's appropriate in a medical home. The Academy has been talking about the medical home since the 1960s. We're happy that everyone else is talking about it at this point. It is something that we believe is the core of pediatric practice and really the way that kids ought to receive coverage and care. And then finally, coverage. Basically, you need kids to have some sort of health insurance. So look at those two children. My gosh, their dad must be proud. Okay, so for healthy kids, what do they need? And this is how we've been trying to explain the ACA to folks, because it is shocking to me. People still don't understand this law. We still have to go around the country and basically explain. I mean, it's a complicated law, but if you're a healthy kid, what do you want out of the health system, right? Well, most pediatric care is preventive. You really don't see kids getting heart disease or cancer very often. Instead, most children actually die from injury in the United States. So you really do need a very different sort of structure for them. And when we asked our membership, both in 1999 and 2007, what do you think is important? If we were to get every kid covered in the United States, here's 6 different options. What's the highest priority? They said benefits was the most important priority. I'm very happy I work for the AP. They said payment rates was the 4th highest priority. But that seems to show to me that they're fighting with insurers, whether it's in Medicaid, CHIP, or private pay, about what those kids are going to get in that benefit package. So benefits are really important for kids. So if you're a healthy child, the overarching concern for that population is a care that addresses their unique needs. So what does the ACA do? Well, one thing that the ACA did is it actually, in Section 2713, allows for all non-grandfathered plans to cover Bright Futures services. Bright Futures is a HRSA product that basically shows what should happen in a well baby or well child visit, and you're supposed to get those in these non-grandfathered plans for no copay. It makes a lot of sense. I mean, if you have a copay, it basically disincentivizes, discourages folks from actually getting that care. Kids should be getting well child visits, right? So no copay for those, have them go get them. Essential health benefits, obviously there's been an enormous amount of work that the National Health Council has done on this. We got a separate category for kids, pediatric services, including oral and vision care. We think those are very important. I think there's some challenges operationally on the ground about how you tuck those into what are normally insurance packages that have not included those benefits. And then, of course, if a child gets sick, you want to make sure that they don't have a pre-existing condition problem. So, children and youth with special health care needs. If you're a kid in this population, it is actually surprisingly prevalent. 1 in 5 U.S. households has a child or youth with special health care needs. That was jarring to me when I heard that and thought about that. 8.8 million U.S. households total. So what happens in that context is most people actually end up having to fill in the gaps with Medicaid. Medicaid basically does that all throughout our healthcare system. It pays for dual eligibles. It pays for kids who might not be getting exactly what they need out of their health packages on the private side. And at the same time, there's about 60% of that population that depends on private insurance. Now, if you look at the overarching concern for this population then, it's really that you have a health insurance package that avoids medical bankruptcy for that family, right? These are the families that are spending a lot of money on health services. So, what does the ACA do? Well, it drops rescissions. Nobody really talks about that anymore, but it's a really important component for people who are sick. And I think one of the things that was mentioned in the past discussion, really, really important, you really want to make sure that these families don't have to spend too much money out of pocket per year. There are going to be populations where you do see true out-of-pocket spending actually increasing. But if you're really using a lot of health services, you don't want to have to spend hundreds of thousands of dollars out of your own pocket. That's what insurance should be doing. And so these caps on out-of-pocket annual lifetime limits, et cetera, that's going to really help this population. So the other thing that's not often talked about is really Section 1202 of the reconciliation component of this. Again, we're the Medicaid doctors. Huge questions in the Medicaid expansion about, are these people actually going to be able to get in the door with a provider? Well, reconciliation actually included a component that raises rates for Medicaid payment to 100% of Medicare. It's a limited set of services. It's only for 2 years, and really therefore becomes our SGR, which will be really fun going forward. But it does apply to managed care and employed physicians based on this new regulation that came out. And from our perspective, what's really important, because subspecialty access is the biggest challenge for kids, it includes subspecialists. So that's sort of an answer to some of these complaints about the Medicaid expansion. Hopefully there will be new providers who will be willing to see more Medicaid in their case mix. It doesn't really often come down to, well, I don't see any Medicaid. It's how much Medicaid do I see for these primary care providers generally. And then the last thing I'll say is that, and I was lucky that I guess this Wall Street Journal article came out on Saturday. I don't know if you all had a chance to see this, but there's at least 3 states that talked about Dennis Smith in Wisconsin, and then Maine, and then I believe one other state. They talked about another component of the ACA, which is really important from our perspective, which is the maintenance of effort provision. One of the sort of rules, one of the lock-ins that happened in the ACA was that states really couldn't change their eligibility and enrollment procedures as a result of the ACA going forward. And actually, for kids, it's until 2019. For adults, it's a little bit shorter. If you take away the ACA, which is what some people are saying saying that the Supreme Court decision gets to. Sorry, if you take away the MOE, the maintenance of effort provision actually has a huge impact on pediatric enrollment. If you see the purple bar there, that's how many more kids are uninsured. So that's a really big deal for us in terms of making sure that states stay with what they're supposed to do under the ACA and really keep eligibility and enrollment procedures the same. So that's very jarring to us. It was absolutely expected after the Supreme Court created some uncertainty about this. We think it's still very good law and kind of a weird ruling or reading of the ruling, but it's predictable that that's where the states are going to go. So thanks very much.